Hi, everyone, and welcome back to our next episode of ReWalk's Topics in NeuroRehabilitation webcast. I'm Kathleen O'Donnell, and today we'll be talking with another expert in exosuit research, Franchino Porciuncula. Franchino is a postdoctoral research fellow at the School of Engineering and Applied Sciences in the Biodesign Lab at Harvard University. Leveraging his training in physical therapy and motor learning and control, he performs biomechanical analyses of human locomotion in populations with neurological diagnoses. Franchino's research focuses on the development and evaluation of soft wearable exosuits that seek to augment locomotion in persons with neuromotor impairments, such as stroke and other movement disorders. His other research interests include the use of wearable sensors in analyzing gait and posture in neurological populations. A common theme among Franchino's research efforts is the emphasis on translation of science to clinical rehabilitation practice. His talk today will expand on some of the research presented in Lou's previous talks and outlines one of the first case studies comparing the results of Exo-Suit Augmented Gait training to conventional gait training post-stroke. Hi, Franchino. It's great to talk with you today.
Hi, Kathleen. Great to see you.
Franchino, I'm really excited to have you on to talk about this study today because it's really one of the first studies that we have, which is really looking at exosuits in more of a progression-based strategy, which is more typical of what we're seeing in clinical practice. And so, I'd love to hear from our viewers as well, who may have clinical experience with the Restore exosuit. I'd love to hear what sort of exosuit progression strategies you are using with your patients and what you've seen to be successful in your clinics as well. So let us know your thoughts in the comments. And please remember to like and subscribe to this video if you want to see more talks like this one. And with that, Franchino, I'm going to let you kind of take over from here.
All right, great. So I'm going to be sharing a little about our early findings on the potential of soft robotic exosuits in delivering targeted gait rehabilitation in stroke. Now, this case study was presented last year at the American Society for NeuroRehabilitation in Chicago. And I look forward to sharing these results and these findings in this webinar and gain more ideas and thoughts, and ultimately to provide some insight to clinicians who might be viewing this webinar. So in the management of gait disorders following a stroke, one of the most important features, and unfortunately commonly under-assessed and under-addressed, is the insufficient ability of the paretic limb in generating propulsive forces while walking. So this essentially prevents the person from moving forward effectively. The resultant gait is asymmetric, it's inefficient and slow, and that impacts daily life in patients post-stroke. Our lab has developed a soft wearable robot, which is called an exosuit. This provides assistive torques on the paretic ankle, assisting with push-off and ground clearance subtasks of the gait cycle. Now, in assessing the effects of the exosuit, it can be assessed based on different levels. And I think Lou has provided a great summary of this in a previous webinar. And I encourage people to check out that webinar because I think it's great material. But very briefly, immediate effect. So effects of the exosuit can be assessed based on immediate therapeutic and retention effects. Immediate effects are those changes that occur immediately as the person is wearing the exosuit, and this is typically examined within a session. Now, therapeutic effects refer to training-related effects, and retention effects are those training-related effects that persist even beyond a period of withholding intervention. Now, our lab has done extensive work on immediate effects of the exosuit, and now we're starting to begin to understand a little about the therapeutic effects. So just a review, in terms of immediate effects, when the person is wearing the exosuit, we see improvements in propulsion, ground clearance, symmetry, and all of these contribute to a more efficient way of walking, which facilitates increases in short and long distance walking. With regards to therapeutic effects, The recent safety and feasibility study of the commercial version of the Exo-Suit, which is the Restore, has shown as part of their exploratory aim improvements in short distance walking function. What is not known at this point are the underlying mechanisms that would explain these changes following training and how these changes and mechanisms compare to interventions that do not use this type of technology. Therefore, our research aim is to examine the therapeutic effects of gait training with exosuits on clinical gait speed function and propulsion in a single person who's had a stroke. We also wanted to examine whether there is added value in using exosuits in training relative to not using exosuits. To examine this, we implemented a crossover design where we compare two interventions, exosuit-assisted training and control training, with a person serving as his or her own control. For our participant, he started with sequence A, which is exosuit-assisted training followed by control training, separated by an 8-week washout period. For our ongoing studies, we alternate between sequence A and B, where the order of administration of these interventions is opposite each other to minimize the potential for order effects. The procedure included in the sequence starts with a screening procedure, checking for eligibility. And then we bring the person in for an exposure visit where the person gains some experience wearing the exosuit in variable conditions, walking speeds at different conditions. And then we obtain a baseline with a pre-evaluation. We administer the intervention, which is exosuit-assisted training, and then we bring him back for a post-evaluation. The same exposure and evaluation procedures are repeated for control training. To examine the therapeutic effects of training, we examine the pre-post changes based on walking assessments without using or without wearing the exosuit. To examine its effects on clinical gait speed, we administered a 10-meter walk test done under fast walking speeds and a 6-minute walk test. To examine its effects on propulsion and other associated metrics, we collected force and kinematic data by having the person walk on an instrumented treadmill, along with the use of motion capture technology. And then we collected these metrics. Our main metrics were peak paretic propulsion, peak paretic ankle moment, trailing limb angle, and stride length. Paretic propulsion here refers to the anterior component of the ground reaction force that corresponds to the force that's being exerted by the paretic limb as the limb is pushing off the ground. And then the contributors to propulsion are ankle moment and trailing limb angle. Ankle moment refers to the torque that is generated by the ankle around push-off, and a trailing limb angle refers to the limb orientation. A more global metric that is related to gait speed is stride length, so we also looked at those. To minimize the influence of speed on these propulsion metrics, walking speeds were matched at pre and post evaluations for each intervention. Now we know that stroke gait is highly heterogeneous, and one assistance profile for one patient might not be the best for another patient. So to optimize our selection of parameters, we evaluated how the person would respond to different combinations of timing and force magnitudes, as depicted here on the middle plot. The way we selected the training parameter was based on how well do these parameter settings are able to generate propulsion. So if you look here on the bar graph on the right, this shows the amount of propulsion that's being generated according to each parameter setting. We selected the parameter that delivered the most amount of propulsion that exceeds the minimum detectable change, or the MDC. If the MDC is not reached, we default into high force and late timing, knowing from previous work from Lou Awad at STM work is that timing is important, and most of the patients responded well with late timing. Therefore, that was our default. In the case of our participant, if you would look at the colored bars here on the right, none of those exceed the dash line here, which is the MDC line. Therefore, we implemented high force and late timing, which is the yellow bar. Our training comprised of 6 visits administered over 2 weeks. For both interventions, walking was directed at fast walking speeds. The only difference between Exo-Suit assisted training and control training is the use of the Exo-Suit. We designed our intervention to be task specific. We wanted the person to improve their walking, therefore we practiced walking. It was also high intensity, and this was achieved by increasing the volume of steps by having the person walk at fast speeds. And it was also progressively challenging. And the progression was modulated based on 2 elements: environmental complexity and practice variability. With environmental complexity, we start with controlled, stable environments, such as the treadmill or inside a clinic, where everything is predictable and constant. And then as the person got better, we progressed to environments that are much more open, where distractions and paths and just general surroundings are much more variable. And this is kind of like simulating what a person would be dealing with when they go out in the community. In terms of practice variability, this was implemented through a paradigm which we call intermittent assistance. This refers to switching, the alternate switching on and off of the Exo-Suit assistance. During the off times, we instruct the patient to keep their speed and to implement the same movements of the leg as if it were being assisted by the Exo-Suit. Every time we switch between on and off, we instructed the patient when that would happen, just to allow them to prepare for it. And then the other component that we recognize is important is active engagement of the participant through goal setting. And practice was also very specific based on therapist cues. Whatever the therapist was seeing in their patient's performance, this was highlighted in the cues. And the cues, again, are in line with what the Exo-Suit was providing, which was propulsion and speed. Now here we have the results of the clinical gait speeds based on the 10-meter walk test and a 6-minute walk test. The red bars here correspond to Exo-Suit assisted training, and the gray bars control training. So what we find after training, there is an increase in speeds and distances regardless of the training. But what is noteworthy here is that the gains in speed and distance after Exo-Suit training is more substantial and clinically meaningful compared to control training. It is also worth noting that these speeds are obtained, these effects are obtained after a relatively short duration of intervention, which is only 2 weeks. One might think that the order might be the main thing that is causing this particular response. However, based on our ongoing studies, what we have been seeing so far is that regardless of the order of intervention, the Exo-Suit seems to be capable of providing substantial gains over controlled training. So the examination of our studies are ongoing, and we look forward to publishing those results and have a fuller understanding. Now, as we have assessed the training effects, gait speed is important, but it is not a complete picture of how the person's responding. So we look at the biomechanical changes. Again, we're interested in propulsion because the Exo-Suit is designed to assist with the push-off part of gait and is known to provide propulsion benefits. So we looked at propulsion and its associated metrics such as ankle moment, trailing limb angle, and stride length. On this particular plot, on the x-axis, we have the pre-post time points, and on the y is the percent change from baseline. And then under or below the pre-time point are the exact values of the baseline to give some context on the magnitude of change. So what we found after Exo-Suit training was a significant increase in propulsion. On the other hand, following control training, we found a significant decrease in propulsion. So these seemingly divergent responses suggest that training with exosuits was capable of restoring propulsion deficits in this patient, whereas control training was not able to tap into that specific impairment. And then looking at the other metrics, ankle moment, again, we see a significant increase in ankle moment after exosuit training, and this is not increased or this is not changed after control training. Similarly, trailing limb angle, another contributor to propulsion, we see significant increase in trailing limb angle after exosuit training and no change with control training. Looking at a more global measure now that is directly related to speed, we see significant increase in stride length after exosuit training, and then again, no change in control training. So in summary, what these findings are suggesting is that the exosuit has potential in restoring gait speeds in a patient post-stroke. And how this is being achieved is perhaps due to the restoration of paretic propulsion deficits. So for the next steps, we would like to administer this study in larger samples to understand its effect across a variety of individuals. We would also want to understand the effects of the exosuit when we implement the intervention at longer durations. And then another thing that we would be interested in is to understand what are the therapeutic effects from a biomechanical standpoint when the person's walking over ground. As it is now, our assessment is limited on treadmill walking environments. I would like to thank the research team who has done tremendous work on this project and is still ongoing, and our funding sources. Thank you very much.
Thanks, Franchino, for a great talk and some really exciting insights into your research. One of the things that I really enjoyed about this talk is it really starts to explore the use of exosuits in more of a kind of a real world clinical training scenario. And it really highlights some of the ways that exosuits can facilitate training of more of a propulsion-based walking strategy, which is difficult to replicate with traditional, and conventional therapy methods. So just wanted to ask you a few follow-up questions. And I would say one of the most common questions that I get asked by clinicians who are new to using Restore is really about that progression strategy. And certainly there's a lot of nuances, and obviously it's going to be patient specific, and there's a lot of different progression paradigms that we could explore. But I'd love to hear you talk a little bit more about the training protocol that you used in this particular study and the overall progression strategy that you used, and in particular, any criteria that you might have used for determining kind of when to advance to that next level of difficulty for your patients.
So yeah, that's a great question, Kathleen. So the way we progressed our intervention was based on the two components, environmental complexity and practice variability. These are elements that are known to modulate learning in stroke. The more variable the practice, the better the learning. The more you take the person out in different environments, it optimizes learning. Based on that, we are also cognizant of the unique features of the Exo-Suit, it being portable, aligned with the knowledge or the acknowledgement that community mobility in this population is severely impaired. There is a long-standing disability. So combining all of those things, it made sense to have an intervention that is salient, that responds to the needs of the patient, and at the same time, a way of progression that is also being supported by the features of the Exo-Suit, it being portable. In terms of environmental complexity, what's really surprising on paper, it seems like it's logical and it does make sense. But as we were doing the intervention itself, it made more sense because we saw how much challenging it was to train out in real environments. And I think that was really important in the training paradigm. In terms of gauging when to progress, I think this is a common question also that we are getting as we talk about our training paradigm. I think there are two main components. One is that, is the person able to achieve the task goal? The task goal for us is gait speed. Are they meeting gait speeds? And then the second one is overall stability and safety. If we progress this patient to the next level, is the gait going to be very unstable, and is the risk for falling going to be much higher than what we want it to be? And then perhaps a third one is looking at overall gait quality. If there's an observable gait deterioration as we progress, we scale back. And I think using these three kind of like check boxes was kind of like pretty efficient in allowing us to decide in the moment when to progress and what to progress.
That's great. One of the really interesting elements in this training protocol is your use of the Exo-Suit Slack mode to provide this intermittent assistance, as you call it, within a continuous bout of walking. And I'm curious if you can comment a little bit more on the rationale behind this strategy in terms of, what are you trying to accomplish here from a motor learning perspective?
So when we implement intermittent assistance, it provides some level of practice variability, which is very important in motor learning. We implemented this paradigm where we switch the system on and off. Again, this is exploiting the system's ability to go transparent in a flick of a switch. And the underlying premise there is that I think there are a couple. For one, it keeps the person actively engaged. The person is not relying solely on what assistance is being provided on top of gait speeds that are being targeted. And the second one is that it provides the person an opportunity to implement what has been learned from when the Exo-Suit is on, to implement and reproduce that. And hopefully that would facilitate learning. Learning happens in different time scales. And in this approach, we are just looking at it from a more immediate time scale within a bout. So those two components we think are important in harnessing the features that the Exo-Suit can provide to the person.
Great. And digging into the data here, when we really look at the comparisons between the Exo-Suit augmented training and the control training, we do see improvements for both conditions in terms of walking speed and 6-minute walk distance. However, the changes are certainly more pronounced in the Exo-Suit augmented training. And these changes are even more dramatic when we take a look at the mechanics of how this patient was able to achieve these changes and improvements in walking speed and walking distance. So mechanically, he was able to improve his paretic propulsion, both in terms of the ankle moment and also in terms of the trailing limb angle, and then more as an overall improvement in terms of his stride length. So how would you interpret the fact that we did still observe these modest gains in walking speed and walking distance in the control training scenario, but without any of these corresponding improvements in propulsion symmetry or stride length?
That's a great question, Kathleen. And I must acknowledge that these preliminary results, as shown on the slides, do not really lend enough insight on that, but that's a great question. So it seems like, so what we are seeing from the data is that following Exo-Suit training, propulsion, there's a targeted effect on propulsion, paretic propulsion. However, when we look at control training, there are still some improvements, modest, however, improvements in gait speed. When we look at the biomechanics, it seems like they are using a different type of strategy. So another force, the opposite force to propulsion, is the braking force, and this is this refers to the posterior component of the ground reaction force that happens when the leading limb lands on the ground. The greater that force, the more the body's going to be pushed backwards. And the less it is, the more it's going to allow the body to move forward. So what we're seeing in following control intervention, there is no change in paretic propulsion. However, there is a reduction in braking force. Therefore, that may allow them to move forward a little bit. In addition, when we look at just general metrics of walking, stride length was not changed. But in addition, what changed was the cadence. There was a reduction in cadence, or there was an increase in cadence following control training. So they are taking, they're not changing the steps, but they are taking more frequent steps. And perhaps these two strategies, although it allows them to gain some gait speed, maybe it's not sufficient to render substantial changes in gait speed.
Okay, so it sounds like if they're being trained without that propulsion strategy, there may be a limit to the improvement that they can achieve without that.
That's right. Yep.
Yeah. And then lastly, I know this is just the first of hopefully many studies which look at various training protocols and paradigms with exosuits. But as you reflect on this early pilot study, were there any key learnings or findings that you would like to see incorporated in future treatment plans, either for your own research or in terms of just general clinical practice?
I think in the treatment of gait disorders across different neurological conditions, well, for this one we can speak about stroke specifically. I think the intervention has to be hypothesis driven. It has to be targeted. Some understanding of the mechanism is really important in tailoring optimal interventions for the person. So in this particular example, the case study, or this particular technology, we are targeting a known deficit in stroke, which is propulsion. And I think that is important that should be part of clinical management. However, this is a very hard deficit to target without robotics. It might be feasible for some patients depending on their clinical presentation, but often when we get patients who are wearing braces, AFOs, these AFOs prevent the very movements that we need from the ankle. So it becomes really challenging for clinicians. So I think exploring possibilities in technology, I think that would be the next step for rehabilitation.
Well, thank you so much for a great talk, Franchino, and thanks so much for your time.
Thank you, Kathleen.
And to our viewers, we hope you've been finding these talks interesting and helpful. So don't forget to reach out in the comments section with the Exo-Suit progression strategies that you see used in your clinic or that you would like to see used in your clinic. And please make sure also to like and subscribe to this video using the buttons below. Feel free to use the comments section to suggest future talks or speakers that you would like to see in any upcoming episodes. And we hope that you will tune in with us again next week. Have a great week, everyone.